So we need to know this with, so we get back to the screen, that's more about purposely damage for the ship. So with normal saline, what we're trying to get at this is that this is the same amount of solution, the same amount of solute, so that whole osmotic variant, do we remember the stuff from EMT about the osmotic variant?
Yeah, we talked about that.
So the fluid, that was that transition of fluids and solutes across the semi-permeable membrane. It's that whole thing of everything always trying to balance out.
Does it let some
So,
things through and some things
what's that?
not? Oh, I was just saying that it let some particles through and some of them.
Right, and so, and the thing is it's, you know, and this is that whole thing of water follows salt. So we know sodium and potassium are the most positively charged intracellular and extracellular ions in the body. So that's where primarily a lot of our fluid shifts are gonna be based on. So that's why we have, and what's the salt, what's the saline content in normal saline, what's the percentage?
Oh, what point?
Yep, 0.9. So, but the idea being is that with that it's supposed to be balanced out and it's not gonna do that shift. So the biggest things that we have to think about though, when we look at and we talk about, oh, this is, people say normal saline and this is, the equal to what's in the body. I had, not last night, but the shift before, we had a bad wreck on 185 northbound at like 3 o'clock in the morning. 2 pickup trucks going way faster than they should. There were beer bottles all around, so we got a pretty good idea what maybe contributed to it. But got in a bad wreck, and the one guy, it was a Ford F-150 crew cab. The roof was completely separated down.
I
It was like
saw
it
the
peeled
pictures
from
of
the
that,
rivets.
yeah.
It's separated at the rivets. And so it looked like somebody had done a textbook, beautiful B-post blowout and roof removal on it. But the dash had come down and pinned his right here on his legs to the seat. He wasn't wearing a seatbelt, so it threw him back and it pinned right there. But he had broken femur, he had and an obviously
2 or 1?
One obviously broken femur. I'm not entirely so. I believe he had, you know,
Some damage to his hip.
more damage here, but he at least had this femur was really obviously
That's
broken.
a leader right there.
And then this one right here, the humerus was an open fracture. Bone sticking out here, rest of the arm bent down here. And he had an open skull fracture right here with a piece of bone sticking
Oh,
out
he
here.
man, you gotta be
Chest
careful.
is sliced up. He's got, I felt
He was
crepitus
bleeding.
on this side, so we know he's got broken ribs. So right now, I'm looking at this and I'm like, okay, we've got some pretty significant blood loss. The medic who got there first, who was on the fire truck, has climbed into the front seat and is trying to start an IV, and that's all. He's like, we've got to get this IV before we move. We've got to get this IV.
Why?
No.
And I was like, why? He said, well, he's lost so much blood. We've got to get this IV.
That's
And
not happening when
that's
you get
not the
out.
point to. And I'm glad that all of y'all get this like panic look on your face. Like, why would you do that?
When you wanna
that's-
maybe
that's
get him
where
out.
we need to be. Right. Now, I get it, his leg was pinned, and so we've got just a little bit of time while they're putting the spreaders in. But, you know, I tried to, I said, look, we need to hemorrhage control, right?
Right,
Yeah.
stop
Let's
the
do something,
bleeding.
stop this blood from leaving him.
Alright.
And we see that he's got, like, he potentially has
Right.
compromised airway, so let's go ahead and start putting him on supplemental oxygen.
Right.
Let's start hyperoxygenating the hemoglobin that we do have. And let's start controlling this bleeding, and let's get him packaged and ready to move, so the second they're done. And I'm having this, it's not an appropriate time to educate somebody in a car, on the road, in the highway in the dark at 2:30 in the morning while they're running extirpation equipment, which, once they ran the spreaders, they left the unit running, and I'm yelling at them to turn it off, and they're going, what? Turn off the generator. We can't hear you.
The generator's
That's because the
on.
generator is running. He says, but we might need it. No, we don't. They're like, but his arm is pinned. I was like, nope, no it's not. It's not, it's just broken. But but I told him, and he's like, we gotta get this IV. So he's got the IV, which is fine. I'm good with getting vascular access. But he is hanging a bag, and he's like, yeah, we've gotta get this. And the guy's getting diaphoretic as can be. His respiratory rate
I was about
is
to
now
say, it's just
slowed
diluting
to-
his
maybe
Chemo.
8 times a minute, probably closer to 6 times a minute he's breathing.
Yeah,
Um,
that's sad.
His heart rate's getting rapid. I'm starting to not feel a radial pulse. I'm like, we need to move him right
Now.
now. He's like, well, I've got to get this IV taped down, or he's gonna, we can't lose this IV.
Yep.
He
So
needs so many
and I
sutures,
pointed, I
I'm
was like,
sure.
I'm not worried about the IV. He's like, I got the Tegaderm on it, let me get some tape, and they're getting ready to move him. No collar. Now granted, it's not my patient, it's not even my scene. We went because the truck that responded called it in as a pin in, and we were the next closest one, and my battalion chief said, go. So we went because we do a little bit more of that than some of the other stations. But they went to pull and they're moving him and they're like, hold on, the IV's tangled, it's catching here, it's catching here. Finally, they yank him and the IV pulls out. And they're like, we lost the IV. I said, good,
Thank
now
God.
we can get on with this and get him in the truck. So we ended up, like, I like Farley. Farley's the medical ambulance out there. He looks, he says, Luke, you're coming with me, let's go. So me and him got in the truck and worked on it and we rectified as much as we could. But I mean, there's only
So much you can
so
do.
much you can do for that. But the thing is the medic that was doing it has been a medic for many years, and it's not that he's a bad medic.
It's what they were taught.
That's what he was taught
2 large
20 years
bores.
ago.
Yeah.
and he is dead set on, but we've got to have 2 large bore IVs and a fluid challenge. And I'm trying to tactfully afterwards, when he called me to ask me how the guy was doing, just to reference that. And he was like, well, we didn't get a second, we just had that one, but we needed to get something on there. And so I'm trying to find a nice opportunity. I wanted to wait to see what the outcome of that. I didn't think the outcome of it, but I didn't want to use this as a coaching moment for him. So, but we have got to get away from the idea that normal saline is the same. And it's not just the whole, okay, it's acidotic, and that more so contributes to the long-term problem. That contributes to the multi-organ dysfunction syndrome, the MODS. But what we've got to realize is that it is nothing but salt water. There is no oxygen carrying capability. There is no clotting capability. There is none of the other necessary components that contribute to the clotting cascade. There's not even plasma, which is the medium that carries the red blood cells. So we have our hemoglobin, so we can transport the oxygen. It's nothing. It is none of those. It is volume. It is the equivalent of looking at your fuel gauge in your car and going, man, I'm down close to empty. You know what? I'm gonna put 2 gallons of water in just to get me by, and then I'll go get some gas eventually. I know that I need gas, but I'm gonna put 2 gallons of water in my car. It makes the fuel gauge go up, but is it gonna make the car run right? No,
No.
because it's not what it needs. So, and just you guys at least are coming up now at a point that everybody's being educated a little bit better. The problem you guys are gonna have is you're gonna be brand new EMTs, and you're gonna know more than these medics that you're gonna go out and ride with that have been doing this for 20 years. Now, you have to be careful about it because, yes, they have field experience, and there's a huge validity to that. But there is a systemic problem in EMS that we do not focus on continuing education. We don't do, as a whole, EMS does not do any more than we have to. So what we end up with is people that don't stay up to date with current information. And so you guys are gonna have to find a way to tactfully educate, meander through it. When you've got somebody saying, all right, we need 2 large wire IVs, you can put out, well, why don't we get the IV access, but he's got a palpable pulse, or he's still somewhat conscious. Why don't we just titrate to effect? Why don't we wait and administer it if we need to? Because it's like they try to get textbook blood pressures. They're dumping fluids and like, oh, we got a blood pressure of 120/80. Great. We just filled it up with water. I'd much rather have a blood pressure of 88/40 and it be actual blood pressure versus just fluid volume. But so while we're on that note, what size IVs do we need to use on people?
I personally like 20s.
Okay,
20s.
justify.
Well, 18s you use for a lot of things for medication and everything, but 20s personally I just like it because it's I worked. They're the ones I've been practicing with the most, and the ones that for some reason they're the ones I always find
There's a reason you've seen good success with those.
because they're just the right size.
And the thing is 18s are okay, 20s are okay, 22s are okay. Now,
That's my first
realistically,
one.
you get too high in 24s. Now, there is a time and a place for a 24, but we don't necessarily, that gives us a lot of restrictions. But we also don't want to go in and, we need two 16 gauge IVs, we need two 14. I've seen people start bilateral 14 gauge IVs.
Okay.
Now,
Jesus, it's fucking strong.
and I'm not counting the times that they've done it because they were agitated with the patient, but I've seen people that have done it because they actually thought this person needed 14 gauge IVs. So a couple of things that go into it. One, when we get into a large enough diameter needle, we can actually start to create and have problems for the hemoglobin. We can actually start to affect the blood cells. One of the things that we have to look at is that when we utilize these needles, when we've got the catheter inserted, it's not just how this vein looks like I can fit an 18 in that. Well, the vein may be big enough
But
to
the fluid
accommodate.
can't get around it, huh?
Right, but when you put that catheter down in, when you put that catheter in, and it's pretty much, occluding everything, we're not getting that good flow around it. We're not getting, number one, we like that Venturi effect. We like the draw, we like the agitation, dilution of it. But number two, we're restricting peripheral blood return from upstream of that vascular access. So, those are things that we need to be conscious of that. We need to also be conscious of the size there. Now, if there are certain medications, there are certain things, if we know that this person needs whole blood product, then I definitely would like an 18 in them because I want to be able to do whole blood product when we get to the hospital. Now, I don't have it on my truck, but so all of these are things that we're kind of taking into account. Other things that kind of get overlooked sometimes would be just simple things when we're selecting vascular access. So what side do we normally start IVs on a patient if they're in the ambulance?
They're left
Why?
just because we're on there. We're on
Because
it.
it's easier, of
Yeah.
course, we're readily available. So, let's fast forward or rewind back to our guy with the injuries that we had. So his IV got ripped out because he used the good arm over here, and he went AC, and it got ripped out. So now this AC is compromised. So we get in the back of the truck,
You have to go
and
above it.
I've got an EMT and he's a good EMT, he's good at what he does. But he looked at the arm with the open humerus fracture and said, I can get one in this AC right here.
Like,
And-
how you gonna do that?
And he saw, and there was vein there, but
Do that
you
make
don't
sense?
use vein on this, number one, just because you don't want to be working on a vein that there's potential upstream damage, or downstream damage rather. But also, that if they're going to be doing surgery, if they're going to do anything else, that they're going to be doing things to restrict blood flow. Like, it just doesn't make sense. However, he showed out because he turned and he was like, and the other arm was still good, we could have gone further up, but we were doing other care, so he drops down to the foot and gets a beautiful 18 gauge right in the foot. All right, cool, we'll go with it.
They
It
did
works.
that last night at the hospital, and I seen somebody who got whole blood. They hang it up just like IV fluid.
Yeah.
I've seen so many lacerations yesterday. I seen artery blood flying everywhere.
So was you
It's
riding on the
neat.
ambulance and just saw it at the hospital, or
Hmm?
was you riding on an ambulance and saw it at the hospital, or was you doing a hospital clinical?
You should be on clinical with Melissa.
I got to do a 4-day-old, a 6-day-old.
So you
I
was
got
up in Midtown then, because everybody I took, I went to St. Francis,
I had
unfortunately.
got like 7
Are you at
days
St. Francis
left
for this
on
one coming
the
up?
IV on the field.
Or you at Piedmont?
No, I was taking all my patients because I was on.
Oh.
Yeah, I don't know where my clinical is that I'm doing my next All it says on my calendar is that I'm doing a clinical.
Here.
I haven't been told where it is.
I'm signed up with yours, yeah.
So
I'm signed up with yours. Let me find out.
I'm doing it in Midtown, but,
I was gonna say,
Oh,
or
yeah.
all of them are at Netflix.
okay, good.
Let me check.
I did CPR on the patient and she died.
Yeah.
Every time I do CPR, people.
I'm gonna need you not to do CPR no more.
But the thing is, if you're doing CPR on them, it's because they died, you know, so it.
Yeah,
Okay.
yeah, it's Piedmont.
But, so yeah, we need to think about things like that, injuries. Now, ideally, you know, down in his foot for somebody, and he did it in this foot, not the one with the femur injury. So, I mean, he picked the one selected limb. But we need to be, that may not be the best choice for somebody that we know has multi-organ system trauma.
Cause you want it up high.
Yeah, well, we want it up close, but then we know that with the types of injuries he had, it's highly likely that he had internal organ damage as well. And we knew that he was going to be going to surgery. Now, what they did is they ended up going up and getting IV access closer up here. They just moved a little further up. But the other option, of course, we have out there is intraosseous. So we know that we have that option going to bone. That used to be reserved for, okay, we absolutely cannot get access, you know, this is one other option we can go with. But yeah, when it came to babies, it was like, oh yeah, we'll just go right into bone. They had dual standards for it. But the thing is, if you get into the appropriate area, and if you get into the bone marrow there, the absorption rate is good. Now, what you don't have is you don't have that flow, you don't have the ventricity, so you don't have that good draw. You can't just allow it in the bag and it will naturally go in with a little bit of gravity assistance. If you're going to actually administer things through an intraosseous access point, you're usually going to have to apply some kind of pressure behind it. So what that means is that when you're doing medication administrations, you really need to kink, it's imperative that you kink the line above where you're administering them so you're actually putting them in, and that you get a good flush behind it so you move the medication out of that line down into the actual bone.
What do you mean?
So when people push the medications, a lot of times they'll just push the medication and then disconnect. Well, that medication's
Oh,
in
you
that
need
drip
the
set
fluid.
line.
Okay.
So you need to push fluid behind it to get it the rest of the way down in. Now, if you've got an IV bag on, you can push it, disconnect, and just give the bag a good little squeeze, and it'll kind of help move that on in. But it's just things to think about with that. Now, what are our intraosseous sites that we can use?
Right here.
And what do we call that one?
The leg.
What's the access point called?
The patella.
Patella's your kneecap.
Mm-mm.
I
I've
know
seen
that.
one person do
I
the
know, but I was
patella,
trying to make
and
up
that
a
was
name.
bad.
I would
I'm
not
trying to make
want
up a name for the spot. I know this. I was gonna say the patella is
the
a
knee,
moment.
the leg. What's
I
the
don't
leg?
know.
What bone
like
is
a
it?
flat-
What bone is it on?
Tibia.
It's not really.
It's
You
on the
not.
tibia. So
I heard
Your
somebody
face went like that? I
tell
was like,
me,
I know I
one
got
of
that
the
right. Hold on a
medics,
second.
He said you actually wanna like when you start it, it's like a space, and that's the access point that you wanna use to go
What is
to
it,
it.
something
And
node or
Because
something
he said
notch?
A lot of people
Tibial
don't-
node or
they
tibial
miss,
notch?
and the needles be breaking and stuff, but they're not going in the right
they're not
place.
going to the right spot.
And it's
So
like a little.
that area right there is where you're
Trying to
aiming
show
for.
us that.
But what we do is we reference the top end. So what bone is that?
It's a
Tibia.
Okay, and we don't go. We use the end of the bone as a reference point
Uh-huh.
and
Right
back
under the
up to
bone.
where we are. Now, the way that you can remember it is, what do you call like the end of a rail line? The terminus, terminal.
Oh,
terminus.
okay.
So it's the tibia tuberosity, and there's some kind of, somebody told me, it's like, oh, it's like, think of it as being like the terminal end of the tibia, and I was like, okay, that kind of, and then somebody else told me, oh, it's the part of the tibia that has open tubes inside that you can absorb stuff, and I was like,
That's
okay,
actually-
that one
That
works.
makes sense.
Okay, I
That one
remember
made, that one stuck a little better, so I was like, okay, tibia tuberosity. But what we're doing is we're actually, that's more so the distal end, and we're slightly coming back. And that's where, you know, they generally say you can feel the bony prominence. That bony prominence is the end of the tibia tuberosity. And then we can stick our fingers in, we measure back, and oh, look, there's that nice, good, flat spot that we're aiming for.
What if they're a chunkier fella?
So The new needles come in different lengths, and they're just for that.
No, I mean finding that spot. What do we do on a
So-
thicker fella?
The whole thing, when you feel there, you know how you literally feel the bone. There's a very few places on the body that subcutaneous tissue does not form in as much of an abundance, and that's one of the places. So the tissue tends, even now, if they've got really bad peripheral edema, then yes, it's going to be a little more difficult. But we're still going to be able to find the bony part of the knee. We may not be able to feel this flat part nice and smooth, but we're still going to be able to feel the bony part of the knee unless they've just got lots of edema. But we can still reach in and kind of feel it. The other thing is we could move to a different spot. The humerus, yeah. And the same thing, we're not going all the way into the ball on the end of it, but, okay. Well, I mean, you can kind of see.
I was about to say
Anyway, I thought we
Jefferson's
had
over there.
What's that?
This
Jefferson's
one seems
over there.
easier
Is that
to
his name?
find.
That's what I named it.
Works for me. But we've got that. Now, what's a third site? Yeah.
Oh,
But we're
no,
not
we
allowed
don't
to
wanna
do
do
sternums
that.
anymore.
You don't wanna
That's
do
what
that.
I've been told.
I'm making me advanced director,
So-
so don't never do that.
So we don't do sternums in the field.
No.
We don't, but it is absolutely something that's done. It's just Georgia has said, no, we're not doing that.
No.
Now, why do you think the sternum would be?
It's all
Because
flat,
you can
bro.
only do it one time. After you do it one time, you can never.
Plus,
do
if you
it
mess
again.
up and you miss or you stab through, you're
Well,
gonna
no,
end up
why-
getting
It's
the heart.
too many meters.
So,
And
well,
plus,
the
if you do
system
chest
is
compressions or
designed-
something like that,
So it does create a problem relative to chest compressions, but there is a very specific use for that one. Who would be a very, very specific use that you could think of?
A person with amputated.
Okay. Why?
they ain't got no bones.
They don't have really anywhere else to go.
Okay. So based on that, you're saying amputated. Well, yeah, we could have somebody that had amputated arms and legs, but more so we see that in blast injuries relative to soldiers. So the military is really big about utilizing the sternal IOs because of the high concentration of extremity injuries from dismounted IED explosions. Because they get blast injuries to legs, and same thing, if there's damage to this leg and it's from an IED, there's probably gonna be damage to this leg. And there's a good possibility there's gonna be damage to arms too. But what it does is it takes all that out of the equation, because if you've got, even if the extremities are still there, if there's significant trauma, then number one, you're looking at somebody that's already hemodynamically unstable. They've already lost a whole lot of blood volume. So because of that, they're gonna have difficulty with getting vascular access. But then you take on top of that we don't wanna access these extremities because they're injured. They may be compromised. So giving that site right there for them is an excellent option. It does offer good absorption. I haven't personally experienced, but from everything I've seen, heard, and can imagine, it is very painful. But I guess pretty much any IO would be painful. But there is unfortunately some videos of soldiers administering it on each other while completely conscious, alert, and
And they
oriented.
just doing it
And
voluntary,
it does
and
it-
you can't never
Well,
do it.
so I wouldn't say everything done in the military is voluntary so much as But-
You're to jump on this
No,
plane. I don't want to, Sergeant.
But yes, there is a video when you watch, and when they fire that in, and he goes, it looks like he is coughing his soul out of his body. But the thing is, there is a specific,
It's funny.
there's a good use for it.
Yeah.
It's just not something that we necessarily utilize in the field, because realistically, we're probably not gonna find ourselves in that sort of situation. Now, that being said,
Is this the one right here?
it looks like it.
There's two of them. Actually, yeah, there's about three. First turn. There's this one, there's this
So,
one, and
I'm gonna pull them up online and put them on the projector a little bit.
there's dope.
We're gonna use some of that as some of our training material for today.
Cool.
But, yeah, so
I
we
just
need to
wanna
know that it
let
is,
y'all
it
know,
is
don't get
something
any
out
ideas
there. It is an option. Now, the stuff that we have on our trucks is not designed for that. The
Yeah,
setups
ours
that
is
we
just-
have. Now, there's a few different things out there. Of course, the Easy IO, these drills, those are the new way to go. And they're they're excellent, they're very proficient. Yeah, you gotta have battery power for them, but, I mean, I've heard people dismiss them simply because of that. That's like saying, okay, I'm not gonna use a laryngoscope because, you know, I have to, what if the batteries are dead? What if you check your truck off in the morning like you're supposed to? You know, it's a simple thing to address. But they're proficient, and they come with different sizes of needles, and they're color coded. So that, to me, that makes things a whole lot easier, because traditionally we look at things, you know, we do things and we have, we have pink for PD. Now theirs is, it's a little more of a red shade, but a lot of things that we'll see indicated with pink for pediatric, it's a variant of red. And it's just easier to think, okay, red, pink, pediatric.
I
But
am giving you a new water bottle, let me know.
hey, come on, he's had that since like 1982. Leave him alone.
Thank God I'm not that old.
Yeah, I was about to say, you probably weren't even born until like 02 or something.
92.
I didn't realize you were that old. Really?
Yes, she's the youngest.
Who?
Yeah, I had.
Me?
Yes.
I'm the youngest?
Yes.
Yeah. So you know you're gonna be
Am I really?
30 soon, right?
Yeah.
And?
Yeah. Oh no, I'm just trying to,
I was-
because I'm gonna be 40, so.
Yeah.
I was born in 82. But,
I just.
so anyway, so they've got the red needles that are the pediatric, and the blue needles are for adults. But then they've got these yellow needles that are the plus size people.
Mhm.
People that have
The fluffy.
extra tissue to go through.
They're a little
So they
fickle.
provide you with that option. And the thing is I mean, it's a nice setup. Now, the ones that we had prior to that, the bigs, have y'all seen those? The bone injection gun. It is,
Oh,
The
that
little
straight
tube,
thing?
like the red tube, the little plastic thing you.
and you push down.
Yeah,
and
that's
spring
Logan
load.
showed me that one from Community. Shit.
So we have those. Now, me personally, we do have one of those thrown in the bottom of our bag as a backup, because we've got on the ambulance the EasyIO, and if I'm going to use one, I'm going to use that. But I have one on there just because it's small and I've got a whole ambulance to put it on, so why not throw one on there?
It's about the
Because-
size of what, 3 pens wrapped together?
Those though, from personal experience, the very first time I used one, we didn't get the in-service training on it because our training captain, who is now a chief, but at the time she was the training captain,
Higgins?
no, Harold, Marie Harold. So she was doing the in-service training on them and had it turned the wrong way in her hand and went to give the demonstration and pushed down and blew the needle straight through her hand. So we didn't get training on those and we didn't get the practice time. So we learned about them, and I knew I had to put force on it, but I was hesitant. Like the first time I used one, I
I'd
said,
be
okay,
using a
I'm gonna
hammer.
push, and I put on it and I pushed, but when I pushed, I was not pushing. I was not expecting the amount of tension and the amount of resistance. So when I pushed, it kicked back on me like that, and I was like, oh, wow. And then I looked and I had bent the needle because I wasn't holding it down good. So the next time I got one, I put both hands on, I got it right in place and went full force on it. Now, I did have an EMT. Now, I know this sounds horrible, but I really didn't care. If he was gonna do it to any patient in the world, he picked the best one. Because this girl, we were going to her multiple times a day. And she OD'd, we got her back, she refused, left AMA, and OD'd in the taxi cab on the way back home. And so
How?
we
In
pulled
the
her
cab?
out in the cab.
What?
Yeah, we don't even know how she got more, because she was still in nothing but her hospital gown. She woke up.
The cab driver.
Left ICU, that's
I was
what
about
we
to say,
said.
she must have known the taxi
That's
driver
what
or
we said. We
something.
said, there's no way she's.
If there's only 3 points of contact, unless somebody dropped it in the cab for her and then the cab driver drove it.
But she straight woke up in ICU, walked down the hall, crapped on the floor 3 times on the way down the stairs, dragging her IV, got to the back door, ripped her IV out and said, I'm leaving. And went outside, got a cab, and went home. And because when they gave the address, we were like, no, no, she's in the hospital. And we get there and there's a taxi cab in the driveway. Anyway, point being, we pull her out to work on her and we said, okay, we need IV access. I had a brand new EMT and I said, you know, she had a long history of everything. She had a PICC line, she had diabetes that she purposely did not manage well. Like, it was a shame.
Why
because
would
so
you
many
not
people-
purposely manage it?
She just would choose not to, because she didn't care. She crushed up medicine and shot it up into her PICC line. So, yes, she did all sorts of questionable things. Anyway, point being, she had no vascular access whatsoever, just everything is shot, and we know this from experience. And I had an EMT with me that says, can I do the IO? I said, do you know how to do an IO? Absolutely, I know exactly what I'm doing. So, okay, I handed him the IO, and we went right about. He went straight center kneecap.
Oh my God.
And that's
He
allowed.
put it on her, and he went, and so we were actively doing compressions on her because we could not, now, we didn't know if it was PEA or just because she had organized activity, but it was at a rate of like 30, and we could not feel a pulse with it. So we're like, okay, maybe this is PEA, or maybe she's somehow like really hypovolemic, we don't know. He popped her in the kneecap, and she had a spontaneous return of circulation and ventilatory effort. Her back arched, and she sounded like she went, "Urgh,"
Oh
and
my
just
God.
leaned back like
No,
that.
that's a zombie. You should
And
have
I
killed her.
looked at him, and I said, what did you do? He says, I don't know what I'm doing. I don't know what I'm doing. I'm sorry. I don't know what I'm doing. And I said, Hodge, what are you doing? Sorry. I'm like, Hodge, what are you? And he's like, and he's like, but she's alive. I was like,
Shit. Ain't even mad at it.
I said, you know what?
Okay, you had
You right.
Okay.
Yeah, you right.
Okay,
Yes,
valid
she is.
point. I was like, next time, let's, yeah.
Let's not
But
do
when you
anything.
did that IO on her, yes.
She took a dip, bruh. She forced it.
She came back from hell. Just like,
That traumatized in real life.
So prior to having those, as traumatizing as that sounds, prior to having those bone injection guns, we actually, the predecessor, that was a big advance when we went to the spring ones. So the old ones, I'm sure y'all seen in an old house, the doorknob, or when you go to a, like a bathroom door that isn't lockable, it's just that
Yeah.
straight, round, small
I got it in
doorknob.
my
Yeah.
house.
Mhm.
I need the
So-
same.
Imagine it is literally a doorknob that is rubber, and then the needle part was on the inside, and you held it and you and twisted like that. There was one model that looked like a doorknob, and there was another model that was a T that looked like that thing you would plug your tires with.
Mhm.
Yeah.
The one you core out and put a tire plug in. That's what it looked, and
How
you
you
would
open the line,
sit
Mama?
there
Yeah.
and yank and push and try to twist that in. And it would, when it went through the skin, it would grind on the bone in your, yeah, and then it would finally crunch and push through.
Yeah, I would have been fine.
Yeah, medicine is crazy. They
Well,
be
the problem
all
is with that,
Why do
it
people wanna
actually would
live?
fracture a little bit of the bone around, and you know, it wasn't a clean puncture. Now, the spring-loaded one, because it was, you know, such a concentrated quick punch, it's the difference, you know how when you do an IV, if you go slow, it hurts more? But you
Yeah,
just
but
go ahead
just-
and you do that, you quick.
They don't
So,
even feel it.
The bone
Really
injection
feel it.
gun, it improved on that. But when we moved to the IO drills, because that needle blade is rotating, it is slow, it's scraping, so it's like using a drill bit, and even though it sounds bad, it goes quicker and it does a lot less damage. It's not it's not breaking bone tissue so much as it's just pouring into it. But I mean, so those are things. Just so you know, there are some other options that are outside of our reach, and this is not like just in Columbus or Georgia, this is period. It is not something that is taught as a field skill. Now, when you get into flight medics, things like that, they are basically having to do the equivalent of anything done in a hospital up in the air. So that's why they've got a lot more parameters of what they can do. But they do central lines. So what they can do is they can actually go and access deep veins. when you guys are doing your hospital clinicals, if you ever get a chance, if you hear somebody say anything about using the Doppler to find a vein or
We
something
watched
like
that.
that.
Yeah,
Yeah,
our very
but
first
I
clinic
gotta
told
do
me,
it. I'm
yeah.
trying
That
to
was
get them to
so
do
cool.
one on my lump right here, but we didn't never get turned
So,
on.
did y'all get to watch how they did
Yeah,
it?
Dr.
Yeah, that was like
Sunil
Kobe
did
for
it.
me.
Dr. Sunil did it
Awesome.
at
Yeah,
Peter.
it was super cool.
Yeah.
Good deal. So,
Yeah, that bitch was mean.
so when you're looking at it though, what everybody has a problem with
Fight people's
is
fingers
that
off.
we're
People
used
like
to
sticking their fingers in them.
we're used to looking at veins, and we think of veins as laying out.
Flat, but they like
Flat.
circles.
And so, so we think of vascular access as like this, okay, it's coming down and it's splitting and it's here and then it's there, and we think of it as being like a road map. But when we're using the Doppler, it's as if we're looking straight down, as if somebody just cut their arm off. Wherever you're looking is a straight down hit.